Hi, you guys. So, this is your recap and review for alterations in tissue integrity, okay, as well as your integumentary disorders. Same thing. All right. So, when you are looking at your alterations, okay, in med surge, the key point or the key part of this is making sure that you've grasped your A&P. Okay, if you have fully grasped your anatomy and your physiology and you know how the body works, okay, then it will be a lot easier for you to grasp the concepts of the alterations and how it's not supposed to work, okay, or when it's not working. Okay, so before we get into our alterations and tissue integrity, you need to know your A&P. Make sure you know the skin layers, okay? Your epidermis, your dermis, okay? Your hypodermis, okay? And even going further, like your subcutaneous tissue, okay? Subcutaneous tissue, or in other names, are also known as, AKA, your superficial fascia or your adipose, okay? You need to know your A&P. So you know your layers of the skin. All right. After you know your layers, now what is the point and the purpose? What is the point and the purpose of the skin? Okay. It serves a few functions. All right. But your main functions that you need to know is that it protects. It protects everything that it's covering. Okay. Those layers, okay, those layers protect the body against infection. All right, ultraviolet light rays, chemicals, physical injury, everything. It protects everything that it's covering. It is your largest organ to protect. Okay, it also provides temperature regulation. It brings the body, makes the body warmer if needed, colder if needed, to cool it down. Okay, temperature regulation. Your skin is also elastic. Okay, it's elastic in nature and allows the body to be able to move freely. Okay, to move freely. All right, it also produces your vitamin D. It produces your vitamin D. It excretes water, ammonia, urea. All right. So these are the things that you need to know. A little pathophysiology, okay? A little A&P that you need to know and have in your mind at all times, especially before you get into the alterations. Okay? So, you know your A&P and stuff now. Now let's get into wound healing, okay? And your 3 steps of wound healing. Your 3 steps of wound healing is your hemostasis and inflammation, okay? Hemostasis and inflammation, then your proliferation, and then your tissue remodeling. Okay, hemostasis and inflammation, that's your clotting. Your clotting is initiated, okay? Your clotting is initiated and vasoconstriction occurs, all right? That stops you from bleeding out of whatever wound that you have, okay? And also in this stage, because of the clotting that's initiated, it begins to make this fibrin mesh over, okay? This fibrin mesh over the wound. All right. Then vasodilation happens, okay, causing hyperemia and edema, making it swell. Okay. Next, proliferation. Okay. Proliferation. This is granulation, okay, granulation in your tissues. So small, tiny little pieces of your tissue begin to repair the vascular structures in that area. Okay, the little tiny little pieces. Okay, when you think granulation, think of tiny little pieces. All right, tiny little pieces of tissue, they come together, all right, to repair the vascular structures. This can start to happen about 3 days later, 3 days after you've had that injury. Okay, and it could take up a week or two to even complete. All right, and then your new vascular network, after the granulation of tissues come together and start to repair the vascular structures, those new vascular structures starts to bring nutrients from the body to the wound to heal it. Okay? After that, then now remodeling happens. Okay? And then now you get a new norm. Okay? A scar. All right? Now it's healed. Okay? It's healed and you have a scar now. That's that remodeling. It'll never heal and go back to normal. All right, it won't, but it's a new normal, a new sense of normal. Okay, get it? So now let's get into some risk factors. Some risk factors and some causes of alterations in the tissue integrity. Moisture. Okay? It's like wetting paper. Okay? Wetting paper. Paper right now is solid, right? But if you wet it, it's just gonna tear away, right? Kind of like our skin. Okay? Skin breakdown. It's gonna break it down. Friction, shear, pressure, okay, pressure especially on our bony prominences, okay, like our elbows, our heels of our feet, okay, risk factors, like other comorbidities, okay, that you may have, and then wound healing, okay, wound healing in itself. Hold on, Cal. Hold on, I'll be there in a moment. Yes, I have kids. Y'all knew that. So we've touched on our process, our wound healing process. Okay, some risk factors that could cause alterations in our tissue integrity. All right, but when you're thinking about all of this and you're thinking about wound healing, I want you to have the term perfusion in your mind. Okay, remember the word perfusion. Perfusion. This is delivering oxygen and nutrients to the wound. Okay, and it's necessary for the wound to heal. Okay, it's necessary for it to heal. Without perfusion or limited perfusion, those 3 stages that I gave you will be highly impacted. Okay, and this is how chronic wounds occur. All right, and you need nutrients. Okay, when you have perfusion, what nutrients is it even going to be able to bring to the wound if you don't have any? Right? You need your proteins, you need your carbs, your healthy fats, okay, or fats in general, but we want the healthy fats, okay. All of your vitamins, okay, all of the vitamins, and you want to take into consideration other comorbidities, okay, other disorders that could play a negative role. So, clients with diabetes, they have delayed wound healing. Okay, so you want to have that in mind when thinking about alterations in tissue integrity and those risk factors. That is a risk factor, okay, and can make things much worse. Okay, so now let's get into our chronic wounds. Okay, when you have a chronic wound, it's been present for a month and more. Okay, it's chronic. It's ongoing now at this point. Okay, it's been present for more than 1 month, and it's not progressing through your normal wound healing stages as it should. All right, that's what that means. That's what makes it chronic. Okay, and you have chronic wound healing and you have excessive wound healing. Excessive wound healing is our hypertrophic wounds, and these are scars, flat scars. Okay, flat scars where collagen has been overprocessed and organized and smoothed out flat, okay, and it's flat surfaced. That's your hypertrophic wound. That's excessive wound healing. Too much collagen there, all right, but it's healed flat, all right. Then you have a keloid. Your keloids heal, okay, but they continue to grow like this, and they're raised, all right. That's a keloid. Those are your excessive wound healing examples. Okay, so moving on to your physiological impact that wounds can have on one's body. Okay, if I have a wound on my face, okay, I will feel a little self-conscious, right? Probably a little anxious or not want to look in the mirror. That can do something detrimental to your mind, your mindset, and your perception of yourself, right? So you want to look at that aspect when you're dealing with your patients. All right, your wound severity correlates with psychological manifestations. Okay, they could experience depression, anxiety, even pain, increased pain, and have a huge impact on the quality of life that they can have. Okay, so you as their nurse, you want to make sure you keep that in mind as well. All right, a lot of the times the psychological aspect of it is overlooked, but you want to be a great nurse. Okay, and you don't want to overlook that. You want to treat the whole patient, okay? Mind, body, soul, okay? Let's start getting into some types, okay? Let's talk about our pressure injuries, okay? Our pressure injuries. Pressure injury. It's an injury from pressure, Okay, this is very common on our bony areas. So like the back of the head. The back of the head, the skin is kind of thin right there. Okay, it's a bony prominence. Our elbows, bony prominence. Okay, our tailbone, or where our coccyx and our sacrum is, bony prominence, especially for somebody that's bedridden, right? And that's laying in bed all day, every day. They can't move, they're immobile, all right? Or the heels, the back of the heels of your feet. Okay, these are your bony prominences where your pressure injuries show up and appear most commonly. Okay, but guess what? They're 100% preventable. 100%. Okay, you have acute ones, you have chronic ones. Okay, your acute ones are probably like the beginning stages. If you catch it early enough, you can probably work on, get a good care plan, game plan, and help to get it back to a normal state. All right, but let's get into your pressure injuries and the stages. All right, your stage 1 of your pressure injury, this is only going to affect maybe the epidermis, that first layer of the skin, and it's going to be a non-blanchable, okay, non-blanchable redness on that area, whichever area it is. Okay, non-blanchable means that I press here, the redness doesn't go away and come back again. Okay, it stays red. It stays red. Okay, that's your stage 1. All right, your stage 2. Stage 2, now it has gone through 2 layers. All right, epidermis, dermis, it's a little opening, maybe a little blister. Okay, that's your stage 2 pressure injury or ulcer. Okay, then you get to stage 3. This has gone through your epidermis, your dermis, and even your subcu layer of your tissue. Okay, now it's a little deeper. Okay, this is where by stage 3, now it's probably not even as painful to your patients anymore because the nerve endings are gone. By this stage, by the 3rd stage, the nerve endings are gone. They've eaten through those, this injury has eaten through those nerve endings. All right, then when you get to stage 4, now I could see muscle, tissue, bone, okay, in this 4th stage. All right, now when you get to unstageable, now you have things like necrotic tissues, dead black tissue. You have slough, okay? It's nasty. It's like where the tissue is like slimy, it's sliding off. Okay? It kind of looks like fat in the fat part on raw chicken. It looks like that. And it has a very bad odor. Okay? These are your stages. Okay? These are your clinical presentations of these stages. All right? So, with that being said, we're going to get into, we staged our pressure injuries, but there's more to ulcers that you need to know. Okay, so we're going to tackle that as well. So this is very key. Okay, this is very key part of ulcers and wounds. All right, we're going to talk about your arterial ulcers, your venous ulcers, and your diabetic ulcers. Okay, your arterial ulcers, this is problems within your arteries and the blood flow. Okay, these are deep wounds that occur, and they have like this punched out appearance, kind of like when you have a hole punch. Okay, it has like a punched out appearance. Okay, and well demarcated borders. All right, it can contain eschar as well, and it has very poor perfusion. So because there is poor perfusion, it's going to be pale. Okay, pale. It could be ashy looking, peeling looking. Okay, the skin on the outside, hairless, and cool to touch. Okay, and why is it cool? Cool to touch? Because the insufficient blood flow, right? All right, and the insufficient perfusion. Okay, so it's going to be cool to touch. That's your arterial ulcer. All right, arterial ulcer. So now your venous ulcers, okay? Your venous ulcers occur because of poor vascular circulation, okay? And poor valve circulation and valve control, all right? This is why you get a venous ulcer. It's insufficient blood circulation and supply as well. And these usually present more on your lower extremities, okay? Typically like the thigh, and it's kind of like an indent appearance to it. Okay, no eschar like the arterial ulcer. The venous ulcer does not contain any eschar, but it is more prominent in your the medial area of your lower extremities, so like your thighs. Okay, these are your venous ulcer. Next is your diabetic ulcer, and this stems from uncontrolled diabetes and neuropathy. Okay, having peripheral neuropathy, they can't feel, right? They can't feel this even develop. So then it starts to worsen over time, and this is more prominent in the foot. Okay, in the foot, and it may may include like a callus on the foot, and if it's not cured, or not really, well, not cured, but if it's not helped right away, it can worsen and worsen over time, and possibly lead to an amputation of the foot. So labs and imaging can also be done, as well as biopsies, taking a piece and sending it to the lab to test it out. Okay, these are also things that can be done to diagnose and to get down to the root cause and the problem of the situation. Okay. Now, when dealing with these wounds, okay, you need to measure the wounds, okay? Measure the width, the height, the depth, okay? If it's deep, which is called tunneling, okay? If you can look down the wound and look into the body cavity, tunneling, okay? So you need to measure that as well. You would need to stick a sterile measuring tape down in there to measure how deep the tunneling is. Okay, you need to measure how wide it is. Okay, look at the borders. Okay, how deep, the location of it, the drainage. What does the drainage look like? Okay, what does the drainage look like? All right, is it just light red, bright red blood? Okay, is it serous? Is it kind of clear, pale pink? Okay, is it serous sanguinis? Okay, is it purulent? Okay, is there pus? Because you know that is a sign of infection. Okay, so you need to notate all of these things and document. If you didn't document, it did not happen. Okay, I gave you the things to look for in an assessment. Okay, now you got to analyze. Okay, analyze the barriers. Okay, the barriers to the wound healing. Okay, is it possibly infected? All right, is it infected? Are they immobile? Okay, have they been being turned how they're supposed to? Are they incontinent in any way? Okay, do they have, because we talked about arterial and venous ulcers, do they have peripheral artery disease? Okay, do they have diabetes? Do they have cardiovascular disease? Do they have these arterial insufficiencies that is leading to these ulcers or causing these ulcers? Okay, you analyze those cues. All right, then you go into your implementation, working your way through the nursing process. Go into your implementation. Okay, create a time frame. Set some small goals for your patient. Okay, if it's infected in any way, what have you been giving their antibiotics orally, or do they need an antibiotic ointment? Okay, their mobility, what's going to change with that? If they are immobile and they are bedridden, then you have they been being turned? If not, get a plan. Okay, I'll turn them the first few hours, you turn them the next few. Delegate to your UAP. All right. Dietary education. Again, I can't stress dietary enough, especially when it comes to this. Remember, our perfusion needs to bring those nutrients to the wound so that it can heal. We need our proteins. Dietary education, provide that. Okay, and provide wound care. What kind of dressings do these need to be covered with? How often do they need to be changed? Okay, and then you evaluate. Did it improve? Okay, is the sizing, it started this big, is it getting smaller and smaller and smaller? What does the appearance look like? Did it move from a stage 3 to a stage 2 then to a stage 1? Right? If they had purulent drainage and you did a culture, okay, you got some of the drainage and sent it to the lab, right, and it came back as bacteria. They started taking oral antibiotics. All right, they put some antibiotic ointment on it as well in the dressing changes. Okay, and now we're starting to see some improvement in the wound healing. That's my evaluation. Okay, I'm documenting and notating the progress. Okay. So diagnosing a chronic wound begins when you notice as the healthcare professional, you notice that it is not getting better. Okay, it has not progressed. All right, it has not progressed through the normal stages of healing. All right, so we said by stage 2, through the 3 normal stages, by the second stage of healing, that starts about what, third day? It lasts about 2 weeks. The third stage starts about like the 21st day. So that's why once it reaches 30 days and it's not healing properly, then it becomes chronic wound. Okay, and it's your job as a nurse to notify, assess, and analyze using your nursing process. Okay, so I also want to do a short recap on you, a few of your most common viral disorders, bacterial disorders, and inflammatory disorders. Okay, your most common viral disorders, I mentioned having herpes simplex virus type 1 and type 2, herpes zoster, which is also known as shingles. Okay, these are your viral disorders of the skin, the most common ones. Okay, type 1, those are your basic blisters, cold sores above the mouth. That's above the waist. Type 1 is above the waist. Okay, type 2 is below the waist. Okay, genital sores. Okay, that is a sexually transmitted infection or disease. All right, and then your herpes zoster. Herpes zoster is shingles. Okay, the people who, the patients who are predisposed to this are those who have had chickenpox in their childhood. Okay, they are more at risk to getting shingles or developing shingles because that varicella lives in their body. Okay, and then your cellulitis. Your cellulitis is your bacterial skin disorder. Okay, cellulitis. It attacks the dermis and the subcutaneous layers of the skin, so it's underneath. All right, underneath the skin. Okay, and then you have your inflammatory disorder. Your most common one, dermatitis. Dermatitis, skin inflammation. You dermatitis, inflammation, skin inflammation. Okay, this is an inflammatory disorder of the skin. Okay, it's going to cause your skin to swell, to itch, to have hives. All right, you come in contact with a stimulus that your body does not work well with. Okay, it's going to trigger your response in your body, and you're either going to swell, you're going to break out in hives, you're going to peel. Okay, because your body does not like that stimulus. It does not like that allergen or pathogen that it has now encountered. So it causes an inflammation of the skin. Okay, and I want to point out a couple of things to you when talking about comparing and contrasting your inflammatory disorder, your dermatitis, versus your cellulitis, your bacterial, because one key difference in the treatments for these or the care of these is that for your bacterial one, for your cellulitis, you're going to treat that with a warm compress. Okay, but for your dermatitis, you're going to treat that with a cool compress. Okay, bacterial warm, inflammation cool or cold. Okay, warm for bacteria, cellulitis, cool for dermatitis. All right, and then what are you going to ask your patients? Like when you're doing your assessment and all of this, and you're trying to figure out, okay, yeah, you're going to ask them about their health histories and all this kind of stuff, their allergies and their daily life. Okay, well, what have you done differently? You know, you're going to ask them all these kind of questions, but you're also going to ask them, especially with dermatitis, you're going to ask them, how do you handle stress? Okay, because a lot of times stress is internal. We internalize everything, but it shows on the outside. Okay, so you can trigger a response and show it on the outside of your skin just by being stressed. Okay, did they do anything different in their daily regimens? Okay, and I'm bouncing back and forth. I'm trying to compare, contrast. Okay, for your cellulitis, all right, for your cellulitis, you're also going to elevate the area. They're going to be treated with antibiotics because it is bacterial, right? They're going to be treated with antibiotics. Okay, Pain medications, they're going to have a lot of pain. They can be treated with pain meds as well. Okay, so just wanted to point a couple of those out, and then we're going to get into burns. Okay, so a quick recap on your burns. Okay, first of all, how you calculate a burn, you use the rule of nines. Okay, you calculate your burn percentage by using the rule of nines. Okay, the rule of nines, the whole head, front and the back of the head, equals 9%. Okay, your arm, one whole arm is 4.5. All right, the upper part of the chest is 9%. The abdominal area is 9%. The upper part of the back is 9%. The lower part of the back is 9%. Okay, the front of one leg is 9%. The back of one leg is 9%. Okay, the private area is 1%. Okay, so if you total all that up, the entire body, it should equal 100%. Okay, 100%. So, since you know that, all right, now we need to stage it. We need to stage it and figure out the degrees. Okay, a first degree burn only affects the top layer of the skin. Okay, like a sunburn, a bad sunburn. Okay, that's a first degree burn. Okay, second degree burn now affects the two layers, your epidermis and your dermis. All right, and now it's blistering. Okay, now you have a blister, or it's bubbling up. Okay, then you get to your third degree. Okay, your third degree burn is now it's open. Okay, it's eaten through several layers in your third degree burn. Okay, after that you are fried to a crisp. I'm sorry, but you are. It would be nice. So yes, anything exceeds that, let me just not go there. But anyway, so knowing your stages of your burns and your degrees, how to degree a burn, first, second, third degree. Okay. Next, fluid resuscitation. Okay, replenishing that fluid and encouraging perfusion. All right, what do we say perfusion was? It is blood and nutrients. Okay, blood and nutrients circulating, getting to that wound or getting to an injured area on the body. Okay, so imagine if you have a burn, or say you have burns all over your body. Okay, your perfusion is not valid. Okay, it's not happening. So you need fluid resuscitation. Fluid resuscitation is going to replenish that and promote perfusion again and prevent hypervolemic shock. Okay, you need fluid resuscitation, and some of the things that you're going to monitor and you're going to assess for fluid resuscitation is a blood pressure. Okay, you for sure need to know the blood pressure. You need to know their level of consciousness. Okay, and you also need to measure the urine output. Okay, because with fluid resuscitation, you're giving lactated ringers via IV. Okay, so again, you're going to be monitoring the blood pressure, their level of consciousness, okay, and their urine output. Okay, I would say I and O's, because how much lactated ringers are you putting in that patient's body, okay, versus how much is coming out. All right. The last thing I want to touch on is on burns is infection control. Okay, you're not only protecting yourself from the patient, but you're protecting them from you. Okay, their immune system is shot if they've been burned. Okay, especially severely burned. Okay, and that protection, that PPE and all of that, make sure you're utilizing that with any open wound. Okay, I don't care how big, how small. All right, protect yourself, protect your patients from you. Okay. I hope this helps. If you have any questions, put them in the Q&A board. All right, and I will see to them being answered. But happy studying, and good luck on your test. You got this.